So today we're going to be talking about melanoma-associated retinopathy and how that would come to neuro-op. So melanoma-associated retinopathy, MAR, is a retinopathy, and of course they have melanoma. So as opposed to CAR, where patients with cancer-associated retinopathy don't know they have cancer, usually melanoma-associated retinopathy people already have the diagnosis of melanoma. And it can be cutaneous melanoma, it can be GI melanoma, it could be choroidal melanoma. It doesn't matter. You have to have melanoma. And as with any retinopathy, the symptoms that we're going to be looking for are the retina symptoms. And the retina-specific symptoms are things like photopsias. They see flashing lights, phosphenes, and they're going to have ring scotoma. So even though it could be a central scotoma, it's often this ring scotoma where the central vision is relatively spared or not impaired at all. And it's going to be bilateral. And normally it has a subacute to chronic and progressive course where it's just continuing to get worse and worse. The other two retina sounding symptoms that you're going to be asking about are nyctinopia, which is it's worse at night, or hemeranopia, which means it's worse in the day, because the optic nerve, it really doesn't care whether it's day or night. Only the rods and cones care about ambient lighting. And so when you hear that symptom, it's worse at night, it's worse in the day, then you should really be thinking about rods and cones, and that's a retina symptom. So photopsias, ring scotoma, nyctinopia, hemeranopia, bilateral, subacute, progressive, you should already be thinking about retinopathy. And you would think it'd be easy to diagnose a retinopathy because you look at the retina, but the problem is the signs. There aren't any. So the person has decreased visual acuity or visual field with a ring scotoma or paracentral scotoma, but their fundus exam is normal. And that's how retina might actually see this patient and refer this to neuro-op, because it can come to us as an unexplained vision loss because the fundus looked normal. And what's worse, in the early stages, even the OCT of the macula and the optic nerve are going to be normal, or fluorescein angiogram or ultrasound. All the tests you would normally rely upon here might all be normal or near normal, and that's how MAR ends up with us. So the way we're going to make the diagnosis now is with electrophysiology, ERG. And so the ERG finding of MAR is very characteristic. As you know, in the ERG, there's an A wave and a B wave, and it is the reduction in the B wave on the ERG that is the characteristic finding of melanoma-associated retinopathy, representing the involvement of that bipolar cell, which is the presumed target. We have serum antibody tests for MAR, and you're really just going to be sending the entire panel of anti-retinal antibodies, and some will have more specificity than others. The treatment is to treat the melanoma, of course, but you could do immunosuppression to treat the antibody component, and the prognosis is guarded and variable, but really treat the melanoma. So you need to know about MAR, which has retinal symptoms, not many signs, and electrophysiologic finding. Treat the melanoma, and immunosuppression might help treat the antibody paraneoplastic effect on the retina.